Hi, this is Gerald Friedman. First, I'd like to thank you for allowing me to speak with you this way. Uh, I have a medical condition which right now makes it hard for me to travel, but I really appreciate the opportunity to address you. I'd like to start with quickly going through 8 points on which I think there's a general consensus, agreement at least, in basics among observers of the healthcare system. And that leads to a discussion of the problems that we face as a movement to reform American healthcare and the areas where I think we have possibilities for action. First, our healthcare system is different from other countries. We rely on for-profit medicine. This includes private health insurance. It also includes for-profit hospitals. It includes for-profit pharmaceuticals, usually financed. The basic research is usually financed by federal government and charities, but it becomes a for-profit enterprise. This difference has grown in the past 45 years. We've been moving towards more for-profit medicine, the rise of Medicare Advantage plans, for example, and Medicaid, HMOs. At the same time that other countries have been moving towards more reliance on public sector and more regulation of what private sector activity happens. Second, we spend more on healthcare than other countries, about 60% more than other affluent countries, which means a difference of $5,000 per person. Think about that. A family of four is spending about $20,000 more on healthcare in the United States than they would in Canada or in France. This difference is largely because of higher prices. We pay 2 to 3 times as much for the same drugs as other countries. We pay more for hospitalization. If you have a knee replacement in Boston, okay, or you could fly to Madrid, have an American-trained doctor in a Madrid hospital, go through your whole physical rehabilitation, and then spend a month traveling in Europe for the same price as it would have cost you in Boston. We use less health care than other countries, but pay more because of higher prices. Third, we finance health care through lump sum payments. Everybody pays the same regardless of their income. The lowest paid secretary at the University of Massachusetts pays the same for her health care, for her health insurance premiums and the care she gets through the insurance program, as does the chancellor at the university, even though he is paid 20 times as much. This puts a particular burden on working people who are paying the same for the health care as their bosses get paid. Fourth, higher prices reflect higher administrative costs. This isn't the only factor. There's also more monopoly profits in the for-profit health insurance system, but a large part of it is because of the greater cost of administering our health insurance system, a healthcare finance system. Hospitals in the United States have just about one person involved in billing and insurance-related activities as every bed in the hospital. The first time I said this, I added that, what on earth do these people do? And of course somebody came up to me afterwards and said, have you ever seen a hospital bill? If you did, then you understand how expensive it is to prepare these invoices. Fifth, our healthcare outcomes are worse than in other countries, and the gap has grown with the spread of for-profit medicine. Our life expectancy is shorter, and on virtually every measure, including maternal mortality, child mortality, diabetes treatment, we do worse than other countries. 6, outcomes are worse because we use less health care. We go to the doctor less than do people in other countries. We go on average 4 times per year. The average for other affluent countries is over 6 times per year. The Japanese go 12 times a year. You may think that's excessive, but they live longer than everybody else. 7, working people have it worse in the United States than elsewhere. This comes because of the higher cost of health care, which is As I said, it comes as a lump sum payment regardless of your income. It also comes because of the reliance on co-payments, deductibles, to restrict access to the healthcare system, or to increase profits for healthcare providers and insurance companies. As a result, many Americans don't use the healthcare system to save money. This is a false savings when you think of the cost in their health, but people don't always know that. A third of Americans report they did not utilize some aspect of the healthcare system because of cost, co-pays, deductibles, etc. This includes as many as 18% who report they did not fill a prescription because of cost. You went to the doctor handed you a prescription, you looked at it, thought about how much it's going to be, and you dropped it in the wastebasket. Not good for health. And not surprisingly, areas in the country that report more people did not use the healthcare system because of cost, those areas have the highest mortality. And this is mortality among working people. It's not among CEOs. 8, virtually everyone agrees that the solution is a larger public role in healthcare. Many agree that the best thing would be to have a single-payer system. I don't know how many times economists and social policy activists have said to me, well, if we could do it all over again, of course we should have a single payer. Why don't we? Because we have built up hundreds of billions of dollars in vested interests in the current for-profit system. All these people who are making profits off of healthcare don't want to see a change. We have $3.3 trillion a year in healthcare spending, and this goes to profits, it goes to salaries, it goes to inflated corporate earnings. All of this becomes a political force against change. Now, what should we do? Where do we go from here? Some of us, including, of course, Senator Bernie Sanders, are ready to just jump to a better healthcare system, single-payer system. There's a growing public support for this and growing activism. I think that's great. I'm all for it. Along the way, the other suggestions have come up. First, many people say, okay, we can't do anything nationally, let's do it on the state level. In about half the states, there are campaigns to establish state single-payer systems. Right across your border in New York State, the lower house of the state legislature has voted for such a system. Such systems could generate large savings, improve health care for the public, improve the distribution of costs. This is what started in Canada. Single payer started in Saskatchewan, one province, and then it moved east and west and became a national system. To be sure, it doesn't do much for people in deep red America who can't, win a state single-payer system, but I'm all for it. Second, Senator Chris Murphy, among others, was in the Democratic platform in 2016, has proposed a Medicare buy-in where people could buy into the Medicare system even before age 65. In effect, this is a return to the public option that Senator Murphy's predecessor, Joe Lieberman, killed all by his lonesome in 2009 during the debate over the Affordable Care Act. Okay, this would create competition for health insurance, private health insurance. It would be a better option for many people who are currently without health insurance or buying it individually at relatively high prices. It does little to improve the general healthcare system. It's a good thing, but it just doesn't go very far. Paul Hewitt and Philip Longman, among others, have proposed Medicare prices for all. Mandate that everybody pay Medicare prices. This would save on billing costs. It would restrict monopoly pricing in the for-profit healthcare system. But with that, it does nothing to regulate the practices of insurance companies. And also, by not regulating the practices of insurance companies, it allows them to do things that continue to push up the cost, the administrative costs of healthcare, ultimately pushing on those prices. A good thing, I strongly support it, but it's limited. Medicare Extra for All has been proposed by the Center for American Progress. It goes further. expands Medicare buy-in, improves Medicare. It's a good thing, but it's limited because it's not addressing the private healthcare system. It's hoping, Center for American Progress, hoping that people will move from the private healthcare system to the Medicare extra system, but no guarantee that that will happen. And if we're going to go that far, maybe we should just go all the way to single payer. Finally, there are various proposals on state level to chip away at the current finance system. Through absorbing elements of a public program. These might include state assumption of billing, tighter regulation of insurance to simplify insurance plans, even a state reinsurance program to assume high-cost bills. I've been working on these proposals. They could be done on a national level, they could be on a state level. They would have the advantage of lowering costs, demonstrating the possibility for effective state action, and also chipping away at the existing for-profit system, thus gradually undermining opposition to single payer. So that's my view of the literature. Sorry I've gone a little over time, but thank you very much for allowing me to speak with you. And hey, when you're in Amherst, come by and visit. I'll buy you a coffee. Thank you. Bye-bye.